Hello, my name is Nupur Shah, and today my topic is lumbar spondylosis. So here we begin. Coming on to the introduction, it can be described as all the degenerative conditions which affects the disc, vertebral body, and the associated joints of the vertebra or the lumbar vertebra. And on the radiograph, we can easily see the signs of degeneration, and that's how we can confirm it. And the types of spondylosis are cervical spondylosis, lumbar spondylosis, and thoracic spondylosis. As the age increases, the chances of getting the degeneration will be more. And though age is the primary cause, but the location and the rate of the change is different from patient to patient. So this is the radiograph. You can see in the first radiograph the degenerative changes in the lumbar spine, that is the AP view. In the next radiograph, you can see in the lateral view, you can see the extra bone growth. That those are the osteophytes. And in the last picture, you can see in the last radiograph, the disc problem is very obvious. The reduction of the disc space is seen, and you can see the other degenerative changes and less lordosis. The other problems of the disc are bulging of the disc, then degenerative disc, thinning of the disc as it is seen in the picture, then herniated disc, and last will be the disc degeneration with the osteophyte formation. So what are the risk factors? Normally it happens after 50 years of age, but it can happen at an early age also. Then occupation, for example, if the patient is a coolie or a potter and he has to lift the luggage and put it down and walk with the luggage and he has to do this work for continuous hours and for longer period of time, then there occurs repetitive strain injury in his back, which will one day lead to spondylosis, or even early spondylotic changes can be seen in such kind of patients. It can be genetic and even because of smoking. What are the clinical features? Clinical features will be low back pain, which is obvious. It will be slow, insidious onset. The reduced range of motion at the lumbar spine will be seen. Muscle spasm in the paravertebral muscles has to be ruled out. Then radiating pain or radiculopathy can happen or may not be there, but it can happen in the chronic stages or the later stages. And what is radiating pain? That is the negative symptoms of motor and sensory problem is not seen in the radiating pain, but in radiculopathy, the negative symptoms such as the motor loss or the sensory loss is seen. So there's a difference, and a local tenderness has to be ruled out. Morning stiffness must be there, and if there is acute stage, then morning stiffness could be there, and difficulty in doing ADL activities. It is very important to rule out the lateral shift in the patient. I'll show you the picture of the lateral shift. This is the lateral shift. This is very prominently seen, but it could be at a little lesser level, means we have to undress the patient and we have to rule out and we have to look it very carefully because it could be at little lesser stage than this. It may not be so obvious in the patient. So what is lateral shift? The patient's spine or the trunk will be deviated to one side to avoid the pain, okay, and if the radiating pain is present, then the therapist has to rule out the lateral shift. Types of the lateral shift are two types, ipsilateral and contralateral. What is ipsilateral? Ipsilateral is if the lateral shift is on one side. Here, for example, the patient's trunk is shifted on the right side. Then, if the patient's trunk is shifted on the right side and if the radiating pain is on the left side, then it is known as contralateral. And if the patient's trunk is shifted on the right side and the radiating pain is also on the right lower limb, then it is known as ipsilateral. Usually, the contralateral shift is more common. What is the differential diagnosis? It is herniation of the disc. Again, it comes under the heading of lumbar spondylosis only. But it can be considered under differential diagnosis. Then second is stenosis, where the narrowing of the spinal canal happens. That is again the aging process, and it could be the osteoporotic pain in the lumbar spine or the thoracic spine. It could be osteoporotic fracture or even a traumatic fracture, which has to be ruled out. Management will include NSAIDs, opioids, muscle relaxants, and corticosteroids if nothing works. And as a physiotherapist, what is our goal? The short term goal will be obviously reduction of pain and increase the range of motion at the LS spine. And usually the flexion range of motion is more restricted than the extension. So we have to improve that, because forward bending is very, very important while doing the ADL activities. And gaining and restoring the functional independence, improving the ADL, and in turn increasing or improving the quality of life of the patient. These three will be the long-term goals. So PT management for pain relief, we will apply IFT or TENS and even moist heat in the affected area. And if the radiating pain is there, then we will place the electrodes accordingly and decide the dosage. If the lateral shift is present, we have to correct it like this. The therapist will stand. Suppose there is a right side lateral shift. The therapist will stand on the same side and pull the pelvis towards him and hold it for a few seconds. After the lateral shift correction, he has to start the other exercises of back of strengthening. And otherwise, without correcting this alignment, we are not supposed to start the strengthening exercises. Otherwise, it will worsen the pain. Other PT management exercises will include abdominal drawing in with the heel slides and with the SLR, cat and camel stretches. In the quadruped position, we are doing multifidus strengthening, that is alternate arm and leg lifting, abdominal curl-ups, and prone on elbows and prone on hands. So this is the isometric exercise. The patient is just tucking in the stomach in the crook line position and holding it. Then in this position only, like in the supine position, we have to ask the patient to do the head press and the heel press simultaneously. In the prone line position, prone line Superman extension, the patient is performing. Then we can also give prone on elbows with hold and without hold. And this is prone on hands. Then we can also give the prone position arm and leg raise. And this is a standing extension. So all these exercises can be given to the patient if he is diagnosed with lumbar spondylosis. And with all these exercises, we can strengthen the surrounding muscles, and we can just give him symptomatic relief, because degeneration is the aging process which we cannot stop. But by these exercises, patient will feel better, and if he continues for a longer period of time, or say for example lifetime, then there are less chances for the recurrence of the low back pain, because keeping the core muscles strong and the back muscles strong is very, very important to avoid the recurrence. This is the bridging on the patient is doing bridging on the physioball. So first we have to do normal bridging, and then this is the progression which is shown in the picture, that is bridging on the physioball with hold and without hold, cat and camel stretches, wall squats. Here the patient has to tuck in the stomach and then do the wall squats till the mid range. This is a supine twist, that is the pelvic rotations. So all these exercises can be taught to the patient and can be given to him, and he has to follow the same protocol even at home. And once the pain reduces, or even once the pain subsides, we have to give him ergonomic advice as per his occupation, and we have to ask him to improve the posture at workplaces or even while at home. And likewise, we can advise home program and ask him to do it continuously, and we have to do the regular follow-ups, and so we can reduce or prevent the rate of recurrence. Thank you.